Okay, hi everybody. Thank you so much for joining today's session. We are pre-health shadowing, and today we're here with Dr. Piper. My name is Manasvi Sharma, and I'm the lead of live sessions at PHS. And today I'm here with Jennifer and Kiara as volunteers. I'll just start off with a quick presentation about PHS, and then I'll pass it on to Dr. Piper. Okay, so once again, thank you so much for joining today's session. We are pre-health shadowing, and we're an international student-led nonprofit for medical advancement. So throughout this session, we have closed captions to accommodate the needs of all students. And if you have any other ideas on how we can be more accessible, feel free to email us at info@priasheldering.com. And also make sure to save us as a contact so you can get our newsletters and we don't end up in your spam. If you want to stay in the loop with us other than the newsletter, you can always follow us on social media. And here are our handles. And my volunteer, Kira, would be dropping these in the chat. And we are a pretty diverse group, and we host students from all over the world. And I'm calling from San Jose, and I'd love to know where you guys are calling from. Feel free to add it in the chat. Los Angeles, NC, California, Toronto, Oregon, Virginia, Dallas, Kentucky. Thank you guys. It's a pretty diverse group. Ooh, Virginia. Okay. Other than this, if you're interested in being part of the pre-health shadowing team, you can do so by registering as a volunteer. And this is 100% remote, so you can do it from the comfort of your own home. And if you'd like to take things further, we're also recruiting, so you can apply to join our leadership team, which is also 100% remote. And you can apply online by the link in the chat or the PHS website. And here are some of the roles we have available. But other than this, if you feel like you'd like to suggest your own role that would be a meaning contribution to PHS, you can also do so, and we're open to your suggestions. Other than this, if you have a high school student, well, good for you. We have a high school training program, which is offering leadership and healthcare education for pre-college learners like you. And for this, you just need to fill out the interest form on the HTP program, which is on our website. Also, the foundation of PHS runs on donations. So if you can, please donate, even if it's like $1. It's really helpful and we are really grateful. Throughout this session, you will have the opportunity to type your questions in the chat. Other than this, you can also try raising your hand on Zoom and our co-host will call you out, and also ask your chat questions during the Q&A. Make sure you take good notes throughout the session because after the session, you get the opportunity to take a post-shadowing assessment, which is available for Dr. Piper on the PHS website. And after completing this form, you get a certificate that verifies your hours. It would be really great if you guys could turn on your camera because this session tries to replicate a real life situation, so it just helps us make it more engaging. And thank you so much for joining. I'd like to pass it on to Dr. Piper. If you could tell us a bit more about yourself.
Yeah, of course. Thank you so much for having me here. This seems like a really great program. I didn't have anything like this when I was going through, and it seems like just yesterday, whenever I was trying to decide what I wanted to do in high school, but for me, it was over 16 years ago, so it wasn't just yesterday at all, and things have changed quite a bit. Um, but I can pull up my screen here and show you guys what functional neurosurgery is, what my pathway was to get to where I am today, and how to get there, and just some tips and tricks along the way. Because I think that probably most of you guys have not even heard of functional neurosurgery. I'm sure you've heard of neurosurgery, but functional neurosurgery is a really niche specialty within neurosurgery that involves basically brain-computer interfaces and kind of advancements in epilepsy and deep brain stimulation, and some other more nuanced aspects of neurosurgery that primarily involved cranial interventions. And for me right now, I'm in my last couple months of training after this kind of long process, and I'm at UCSF currently as a functional fellow. There's only one fellow usually, and there's only usually about 20 of these fellowships across the country or so. So it's a pretty small subspecialty. And of course, I had to ask, AI what functional neurosurgery is just to stay up with the times. And this is what it showed. I asked him to generate an image of what functional neurosurgery is, and it actually did a pretty good job, I thought. So it says here, the traditional neurosurgery is removing and repair anatomy, and this functional neurosurgery is modulating the brain. So a lot of it involves things called the deep brain stimulation, where you put an electrode deep in the brain and you try to program that electrode to a certain frequency and stimulation parameters to try to improve upon aberrant firings in the brain. Or it involves different ways to do minimally invasive ablations or other procedures that involve pain neurosurgery. So I thought it did an okay job, and it also involves kind of understanding the connections amongst the brain. Functional neurosurgeons often study, what is the brain doing, not where it is per se. So, but we'll go into more details for that very shortly. Let me get this out of the way. So, this is just an outline of what we'll talk about today. What functional neurosurgery is, what my path was, what it means to be a functional neurosurgeon, and go over a couple cases to make it interesting. And then we'll go a little bit more broad into what my path was, or what a medical path to becoming a functional neurosurgeon would look like. And these two pictures do kind of highlight it. It's not one size fits all. You may see this presentation and try to emulate it exactly, and that's not going to work for everyone. It's really more about what you're passionate about, and following that, and just staying driven and passionate about what you like. And it may end up in functional neurosurgery, it may not. So always having an open mind is important. And I did title this a pathway to functional neurosurgery and a functional life, because the nice thing about functional neurosurgery is a lot of neurosurgery can seem pretty daunting, hard hours, lots of call, and some of it is, of course, but there's definitely some advantages to functional neurosurgery, and a lot of it is longitudinal patients that you spend a lot of time with, a lot of elective surgeries. So a lot of it can be pre-planned. It gives you a little bit better hours, and it can be a little bit more of a gratifying life and kind of well-rounded life than some of the more trauma-based specialties. So, what is functional neurosurgery? This is more of my definition. It involves a subspecialty of neurosurgery focused on modulating neural circuits to improve the function. Opposed to kind of removing tumors and fixing structural damage. Although, that can be a part of functional neurosurgery. You want to kind of imagine the subspecialties within neurosurgery and a lot of the surgical subspecialties as like Venn diagrams, where just because you're a functional neurosurgeon doesn't mean you might not take a job where you're taking out brain tumors as well. So there's a lot of overlap, and in my future practice, I'll do brain tumors and DBS and epilepsy surgery. So, in other words, it's a surgical subspecialty focused on studying and learning how the brain works and not just how it looks. And I really see it as um, kind of like these first three categories, these main expertise areas is deep brain stimulation, epilepsy, and pain. And then computer brain interface and brain mapping are two more niche subspecialties that are more in the research area of functional neurosurgery that are really growing right now. So, functional neurosurgery, deep brain stimulation. Up here in the top right, you see this man playing guitar with his head frame on, and then you see the surgeons behind this clear curtain, and they are implanting electrodes in his brain right now while he's awake. So, what it often involves is putting electrodes deep into the brain, and once you have the electrode in, you record the brain and you listen to the brain cells to try to confirm you're in the right place. You use imaging to confirm you're in the right place, and then you actually will test the patient. Sometimes you can evoke responses that you can hear on the recordings to know you're in the right place. And then other times like this is kind of a niche surgery that was being done here where they were testing a person's guitar skills because he was an expert guitarist to make sure that they were not causing any aberrant problems with his guitar skills because it was important with him. So it's relatively rare that you see someone with a instrument in the operating room, but it can happen with either deep brain stimulation, where you're trying to modulate circuits and make sure you're not disrupting already functioning ones and make sure you're improving upon non-functioning or improperly functioning ones. So once you get the electrode in the right place, then down here in the bottom right corner, you can see this animated drawing of a man with a electrode deep in the brain. It looks like down in the thalamus here. And then you tunnel this wiring underneath the skin down to a pulse generator here, which has the battery that functions and then also has all the programming that allows you to connect to a tablet and adjust the stimulation parameters that you'll use to try to improve this person's dysfunctioning circuits. And then, so that's deep brain stimulation. It can be used for a lot of movement disorders and psychiatric conditions and being explored for other reasons. And epilepsy surgery, if you move over to the middle, this is called SEEG, stereo EEG, which is when we put electrodes deep inside the brain in areas that we're concerned that may be improperly firing and causing seizures. And then we record those while they're setting in place and try to find the specific area that's actually where the seizures are arising from. And then we will either implant something in that area or try to remove or ablate that area to cure their seizures. And then uh, language mapping over here, you can see this is a brain exposed where they have these intraoperative electrodes on the surface of the brain, and they're testing these areas, and they provide stimuli. And either while the patient is awake, you're looking for changes in their talking, and you're asking them to repeat things or say certain things, and then that can allow you to determine what part of the brain is actually producing the function of speech. And then you can implant more permanent surface electrodes like this. This is a grid here that is similar to these SEG electrodes, but they're on the surface of the brain and allows us to record from more cortical surfaces or gray matter so that we can try to see if seizures are coming from there. Um, and in this specific case, after the area was determined that it was like near 37, 38 here, this patient went on for a second surgery and resected that area to try to cure their seizures. And this can be done in tumors as well. And yeah, so epilepsy or tumors, this is common, and functional neurosurgeons are often expertise in this. And then pain neurosurgery is a very broad area of neurosurgery that can either involve implanting certain stimulators or pumps to deliver drugs, or doing more rare pain procedures to try to improve upon someone's chronic pain. So, uh, how do you get to functional neurosurgery? This is my daughter wearing my scrubs, and you start with this, and then you try to go to this, and it's a long process. I'll show you exactly, what the details are. You start with undergraduate, which is 4 years, medical school 4 years, and then residency for neurosurgery 7 years, and importantly, 79% of neurosurgery applicants take at least a year of research or subspecialty learning prior to residency. And then it's up to 20% of neurosurgery residents have PhDs now. And that typically takes 3 to 5 years. So you're looking at most people are taking over an extra year. So, we're at 8 plus 8, 16 years now. And then fellowship. So fellowships are not required for neurosurgery, but to do functional neurosurgery, it typically is required. You can do functional procedures on your own, but if you really want the full gamut of it and, to get a job at a high caliber place, you need to do a fellowship. And those can be 1 to 2 years, with the majority being only one. There's a couple in the country that are 2 years. And then you can do this infolded. This is kind of a new idea amongst a lot of specialties where you have a residency for 7 years. Some specific residencies will allow you to do your fellowship as, year 6 or 7 or year 5, depending on what type of training you're trying to learn. And so, in summary, after high school, you're looking at about 16 to 20 years on average to become a neurosurgeon, starting your, first attending level job. So, you're looking at about 36 years old before you're really going to be, off on your own, making a living and, with a very clear pathway of what you're going to be doing. Because, at each of these steps, it's tough. You really don't know where you're going to end up. You can have an idea and have regional preferences, but when you apply from undergrad to med school, some people apply all over the country, and and same thing with residency. When I was applying, almost everyone applied to every single neurosurgery program. So it was pretty common for that, and now they've improved upon it a lot, so you can narrow that more. But still, it can be hard to plan. So that can be tough. Yeah. So my path, I grew up in Missouri. I went to high school there, and then I went straight from high school to University of Arkansas. I studied chemistry and physics, and at that time, I really wasn't sure um, what I was going to do. I was thinking I was going to, study maybe pharmaceuticals. I thought that by learning chemistry, I would be able to really impact a lot of people by trying to improve drugs, and that was just my idea at the time. And then I really learned after shadowing in undergrad that I really like to interact with patients, and I thought it was a really gratifying profession to go into medicine. So I chose to go to University of Rochester, New York, for medical school. And during that time, I actually largely chose it because I was thinking of doing a PhD and an MD at the time, but I hadn't decided for sure. So I started to get involved some research to determine if that's something I wanted. And at first, I kind of largely did outcomes research where you study large databases and you look for commonalities amongst patients and have like a pretest hypothesis and try to determine if something is predicting, maybe a poor outcome after a surgery. And I like that. I thought that it was interesting research, and I really liked the clinical aspect of medicine more than I did the research aspect. So I did not do a PhD, but I did a lot of research, and I wanted that to be a part of my life. So I didn't decide I wanted to do neurosurgery until maybe my second or third year of med school, somewhere around then. I was always kind of interested, so I was doing a little research in the neurosurgery department, but I had considered other subspecialties, and I tried to keep a really open mind, which a lot of people will tell you to do, and you really should. It's you never know where life will take you, so. But then, I decided to do neurosurgery largely because I liked the diversity amongst it. I remember shadowing a neurosurgeon, and he, did a carpal tunnel release on the hand, and then next he took out a tumor out of someone's skull, and then later in the day he did spine surgery on the low back. So, he was operating all over the body, and all these patients did really well. Two of them went home the same day, and they woke up and was incredibly grateful. So, I thought it was a really gratifying subspecialty that can be very diverse and still has trauma and still has elective surgery. And then also, it's kind of on the forefront of, research and translational medicine. It's constantly growing. It's going to be a field that, what it is today is not going to be what it is 30 years from now. So, I think that's an exciting part about it. And you can say that about a lot of subspecialties. But neuro was something I was always interested in. So I went to University of South Florida in Tampa for residency. And during that time, I even jumped around amongst subspecialties in neurosurgery. And I started studying a lot of complex pain procedures. It seemed like an area that was really like understudied. And I was really interested in like the anatomy of the brain. As well as the physiology of the brain. And, I was just navigated towards cranial side of neurosurgery. So, skull-based neurosurgery is a subspecialty that studies a lot of the nuances around the brainstem, and a lot of tumors can grow there, and it can be a very challenging area to work. So a lot of people see, skull-based neurosurgeons as kind of the experts in anatomy around that part of the brain, and functional neurosurgeons can sometimes be seen as the experts in like the physiology of the brain. So, I was kind of torn between those. So I actually did an enfolded fellowship in skull-based neurosurgery during my fifth year and was interested in that. But ultimately, I chose to do a postgraduate fellowship in functional neurosurgery because that's really what drove me the most. I thought that computer-brain interfaces and the growing field was really just exciting and something I wanted to be a part of. So I went to University of California, San Francisco, UCSF, where I'm at right now, um, which has been an incredible experience. I can't speak highly enough about the people I work with, Dr. Chang here and Dr. Starr, really pioneers in the field. So, and Dr. Wong has, really is constantly pushing the boundaries of what we can do with DBS surgery. So, really great people to work with, and I really value, academic diversity, so that's where I kind of chose to jump around. But, some people stay at the same place their whole career, and they do great as well. So again, it's not one size that fits all. So just something to be aware of, and who I am. You can have a full life in neurosurgery. Don't let people tell you otherwise. It's a common misconception, and it can be aggravating. You'll have long hours for sure, but you prioritize things that you love. So I ran several ultra marathons during residency. Um, Developed great friendships, relationships. This is my co-resident, Jay Kumar, who we did like everything together. We started residency together. We were the only two residents, and we had babies within like 2 weeks of each other. We went to the same place for fellowship. So, you have great friends for the rest of your life. I'm an avid rock climber out at Yosemite there. I love to rock climb. I find it's a great way to meet people when you move around to different cities. And, there's a lot you can do with life outside neurosurgery. And, I have a daughter and I have a second one coming. So, of course, you're in scrubs and half your pictures, but, you learn to have a full life. So, don't be threatened by it. Uh, I will say, time is definitely very valuable. And, if you are someone who maybe has 40 different hobbies, then, at some point you do have to kind of consider, maybe I focus on two or three of them and really think about what it is that, you are enjoying out of them. And I wanted to stay active and I wanted to be outdoors. And, I think that like running and climbing are two things that, hits two of those things for me. So, just really consolidating your time and prioritizing to what you feel, you know, helps you the most. So, I just wanted to show you guys, what does a typical day or week or month look like? Because I remember going through this process and just being so confused about, what actually people were doing day to day. So, I'll just show you, what a typical week looks like for me. So, in fellowship at Mondays, like 6 to 8 a.m., I start doing emails and I'll round on patients in the hospital. Maybe I have two patients admitted, maybe I have 10, and that will kind of determine whether I'm rounding for 2 hours or rounding for only 30 minutes and doing emails the other part. And then I usually do clinic on Mondays, like 8 to 4, and then 4 to 6. Before I go home, I finish up any meetings, like research meetings, I try to schedule then, or and maybe go see another patient that was, maybe they had bad pain in the morning. I want to check on them again, or, something concerning, just go check on them again. Um, and then Tuesday is like an operating day for me. So the ORs start around 7 a.m. and then they can last till about 7 p.m. for this day, types of surgeries we're doing. So usually 2 to 3 epilepsy surgeries and maybe 1 or 2 pain surgeries mixed in there. So about 12 hours there and then, home right around 7:30. And then Wednesday, usually two deep brain stimulation surgeries. We can do these relatively efficiently, and we're usually done a little bit earlier. And either I'm finishing up work or doing research meetings, or trying to get home early if there's something I scheduled with my family. And Thursday, 6 a.m. to 6 p.m., relatively variable. This is kind of a flexible day depending on what's going on then. Sometimes I'm operating if, one of my fellowship directors has an extra case that needs to be done. Sometimes I'm doing meetings, all day. Sometimes I know one day a month that this Thursday will be blocked off and I just load up all my meetings, and sometimes it's clinics. So. relatively variable. And then, Friday is what we call, an academic day, where, I get up, I do meetings, I do research, I plan for surgeries. There's a lot of times with your surgeries, you have to review imaging, review results, make sure that you're choosing the right surgery for a patient, or you're doing conferences, either meeting with other residents. Or even, you may be preparing for, a national conference that you got to give a lecture at or something of that type. So weekends really depend on the type of job, but typically 1/4 of the weekends I'm usually working in some capacity, whether that means attending a conference on, let's see, in April there's one that's just a national general neurosurgery meeting, and then in June there's another one that's specifically focused on like DBS and stereotactic neurosurgery. So I'm going to both of those. There's courses. Sometimes you're teaching or help teaching, or you're actually attending. During residency, you attend a lot of different courses where they maybe a company or a hosting institution will fly you out there, and you'll meet other residents or fellows, and you kind of go over and collaborate on different ideas and learn new techniques. And then there's call. Functional neurosurgery has a little bit less call than most of the other neurosurgery, but that means that you're at the hospital or nearby, usually within 30 minutes, and answering calls. And if there's an emergent surgery, you have to do it. And if there is a non-urgent surgery, then you go see the patient and you try to plan a time to do the surgery. And then, of course, just catching up on research. Sometimes you just get bogged down and you have to, spend a Saturday where you're just catching up on everything. Sorry. So yeah, beyond in-hospital work, there's about 20 hours of work a week, and in residency, it can be close to 30 hours a week of just planning for the next step of life, whether that's preparing for fellowship or preparing lectures or doing research. In residency, you tend to have quicker deadlines where maybe an attending asks you to help them prepare a lecture by the end of the week. So it's a little bit more variable, and your time's a little bit harder to predict. So training years are different than your work years. It can be harder. There's an 80-hour work limit, and you can go over that, but you're supposed to be 80 hours on average over a month. So there are weeks that you may work 90 or 100 hours, and it is busy. Like, you're barely functioning outside the hospital, but you learn to do everything in the hospital incredibly efficient, and you learn to do it really well. And then, there's less busy years, I mean, in training that are 50 hours a week, maybe. So, just because it's 7 years, don't imagine that you're going to be working 100 hours every week for the next 7 years. You can definitely have a life in there. And then, postgraduate jobs can be very bit variable. I mean, within the academic or the community or the private practice world, it can be just as busy. It can be 80, 90 hours a week if you're, really trying to be incredibly busy, or there's some hospital or academic program that is really pushing you, or it can be closer to 40 hours. So that all really depends on what you want out of life. So um, don't have any, uh, false notions that you have to be working 90 hours for the rest of your life. So that's definitely not true. So I just figured we'd talk about, a couple cases just so you get a little bit better idea of functional neurosurgery. So this is case one, 20-year-old with new onset convulsive seizures, history of infantile seizures, and otherwise no significant medical history. Is started on lamotrigine, continued to have seizures despite trialing multiple other anti-seizure meds, levetiracetam, lacosamide, cenobate, and midazolam. And so now they've failed more than two seizure meds, which qualifies them as treatment refractory epilepsy, and that's when you're a candidate for epilepsy surgery evaluation, at least. So this patient has seizures by having anxiety and then nausea and dry heaving, which progresses to these generalized convulsions and loss of consciousness. Uh, Studies that we did initially were non-invasive scalp EEG, which helps you identify where the seizures may be coming from, and how the seizures may be spreading, and then an MRI, which is just a scan to look at the anatomy of the brain to see if there's any abnormalities. So scalp EEG was suggestive of left-sided seizures, temporal onset, which is this area of the brain, And the MRI suggestive of right mesial temporal sclerosis, which you can see pretty clearly right here. On neuroimaging, everything over here is the right and this is the left. It's flipped. But yeah, so it's actually not conclusive because the EEG is thinking the left side and the MRI is saying the right side. So in this case, this is when you want to start doing additional testing to try to understand where are these seizures actually coming from. So this is when we do something called stereo EEG in certain situations like this, where we implant electrodes like this into important areas like this, hippocampus and amygdala. And you put electrodes in just by one incision with a very small scalpel, and you use a stereotactic system, kind of like a GPS system, to make sure it goes in the right area. And then you leave those electrodes coming out of the skin for anywhere from a couple days to weeks, and you actually take the patient off their seizure meds, and you watch on screens or computers transmitted through these electrodes going outside the brain to see where their brain activity and their seizures come from when they start to have seizures when you take them off their medication. And then uh, Oh yeah. So then this patient, we did that, and the SEG showed that the patient was having right-sided seizures coming from the middle or kind of middle portion of the temporal lobe, and therefore, what we did was we actually placed I think yeah, here we go. We placed a laser down this along the long axis of the hippocampus down to the amygdala. We did something called a selective amygdala hippocampectomy via laser interstitial thermal therapy. So you place this in there, and it's a laser probe with a cooling system going through it, and it actually burns that area. And it's done with one small incision in the back of the skull. It just needs one stapler stitch at the end, and you can see this is during it. This is called MR thermometry, where you can actually measure the temperature of the brain. So this patient gets this electrode placed stereotactically. They go into MRI, and then we burn that area as MRIs are running, and we can tell that we're burning the right area. And then we get a scan afterwards, and you can see this whole area was all ablated appropriately, and we knew that the brainstem right here, right next door, was never bothered because we had temperature sensors based right in there on the MR thermometry to make sure that nothing was injured. So after this, the patient had no seizures. She was able to get her driver's license back, or will be very soon if she continues to not have seizures. And then all this was done with a small incision. And just to show, like epilepsy surgery can be really incredible, very minimally invasive. And about 200,000 people a year in the US qualify for it, but only about 3,000 people are having it done just because of fears amongst brain surgery. So it's a really amazing underutilized tool, and something really exciting. So case two, a 70-year-old with a Parkinson's disease, progressive tremor, bradykinesia, rigidity, and he can't feed himself anymore because his tremor is so bad, and he can't walk more than 100 feet without being worried about falling. He's on really high doses of carbidopa, levodopa, which is dopamine replacement, because these patients are really they have a problem with their dopamine um, their dopamine being processed in their brain. And since they're on such a high dose of this medication, it causes dyskinesias, which are very large amplitude, sporadic movements of their arms. So they have tremors and dyskinesias. This can be really problematic. So we did these tests. Dopamine challenge showed that when they take this medication, their symptoms improve. We did neuropsychological testing, which shows they don't have any of the non-motor symptoms of Parkinson's disease, and then physical exam showed otherwise they're healthy. So for this patient, we offered deep brain stimulation of the subthalamic nucleus. So this is what I was showing you earlier. We place a frame on them. This is a animated image of the frame, and then we have an imaging system that we pick out the perfect area to put the electrode, and then we do CT scans around their head with the frame on, and we can set this stereotactic system to target that very specific area by using kind of GPS coordinates based on the CT in this frame. And then we place the electrode in, and we record the brain as you're placing it down, and then you actually turn it on and you test the movements of the arms, and you watch their tremor actually like subside as you turn it on, and you test to make sure you're not causing any other side effects when you turn on the DBS system. And this is just a picture of some of the systems, kind of similar to what I showed you earlier. We can make 3D models of these areas to show the volume of tissue activated, that we're hitting in the right area, and we have multiple contacts that we can choose which one to basically choose the best target for that patient, even after we have it implanted at all. So, this patient, tremor completely eliminated, able to feed themselves, clothe themselves, medication decreased by 50%, eliminating their dyskinesias, and they can walk over a mile a day. No recent falls and doing amazing. So this is a very classic story of DBS. It works incredibly well for the patients that qualify for it. So, some of the research that I'm doing, I've been in a lot of different areas of research, and I'll kind of talk about that in a little bit. But what I'm interested in a little bit now is SEEG guided DBS. So for more rare things and things that are up and coming, such as OCD and complex pain syndromes and depression, we're finding patients, and we are doing this SEG trial that we use for epilepsy. And we leave these electrodes in, and then we actually test all these different contacts, all these little ones in here, and we try to find areas that are specific for each patient, and try to find the best place to put a DBS electrode so that we can do chronic stimulation for these patients and see what part of the brain is actually involved in these different disorders. And then once we figure that out by leaving these in for about 14 days, 10 days, um, then we move on and we actually implant them permanently in them. So it's kind of a new area that's exciting because it involves epilepsy surgical techniques as well as DBS surgical techniques. So, and here's just a quick clip kind of from CNN of one of the colleagues explaining
It's
it.
called the fifth vital sign, right? But unlike the other four vital signs, there's no objective measure, right? It's not like temperature or heart rate. So one of the holy grails of pain medicine has been coming up with a biomarker for measuring how intense or how severe somebody's pain is. This is exactly an example of the device that.
So Travolker has made this his life's work and has an audacious plan to try and measure pain. To start, surgery to stick multiple probes all over the brain.
Like it's this device kind of it goes above under the scalp and connects to one of the wires going into the brain.
Scientists then simply listen to the billions of neurons in the brain and see what areas fire up when the patients have pain.
So it's just a quick summary. I figured he could explain it better than I could, since he prepped for that for so long. But Prasad's an amazing guy, and he's really kind of one of the pioneers behind this research here at UCSF. Yeah, so choosing, I'll go back to research here in a little bit, but choosing a neurosurgical subspecialty. This is just my summary of functional neurosurgery, some of the pros, some of the cons. Pros, like I said, it's constantly evolving. It's really cutting edge of neurosurgery. We're starting to do a lot of neuropsychiatric brain implants, which is really exciting. It can be, a delicate area to get into, but I think we can help a lot of people. It's got a really bright future. It's a very diverse practice, and patients do incredibly well. It's not uncommon that I get an email or a message in the Epic system or healthcare system, from a patient saying how great it is and how it's changed their life. You operate on a lot of younger epilepsy patients, a lot of older DBS patients, so patients from all over. So it's a lot of elective practice. A lot of patients, you're working closely with a neurologist, and they will come in through clinic. So a little bit less than some of the others, some subspecialties such as spine or like neurotrauma. You may get a lot more of your referrals or consults from the emergency department or from inpatient when someone's having like a pain exacerbation. So you have a little bit more predictable schedule in that sense. And the jobs are becoming more common. It's not impossible to find a job, not that is, not even just in academic medicine, but in community hospitals to do this type of surgery. And it's really a team sport. You have to work with a lot of neurologists. Functional neurosurgeon is probably the neurosurgical subspecialty closest to neurology because you're working with so many, the epileptologists or the movement disorder neurologist. The cons are it is becoming more competitive. To get an academic functional neurosurgery job is relatively difficult. And usually you have to either give up on some subspecialties within functional neurosurgery and maybe hone your specialty just to DBS or just to epilepsy, or be a little bit more flexible in where you're willing to move. The compensation is slightly less than general neurosurgery. There is slightly more. This is probably one of the bigger things on why some neurosurgeons don't choose it, is it's a lot more minimally invasive surgery. So um, it's less common that you have, a large incision where you're dissecting things out under a microscope. It's considered maybe a little bit less physically complex or demanding because you're often drilling a hole and doing a lot of work on a computer and putting an electrode in a very specific area. So it can be cognitively relatively taxing. Comparatively, if you're doing skull base, you may be under a microscope dissecting a tumor out for 8 hours, and that's less common in functional neurosurgery. So, uh, the research can be difficult to fund and does require a lot of collaborations, but research is always really a big part of functional neurosurgery. And because you have to work with a lot of people to get referrals outpatient, it can be a little bit difficult to build sometimes. And then again, some people don't want to be a part of a team sport, so that could be a con if you're more of a lone wolf. So if you're interested in functional neurosurgery, this is what I would say. I would say, shadow. This is a great start. Sometimes it involves cold emails to departments, local hospitals, organizations. Always keep an open mind. Remember that neurosurgeons are really busy, and most neurosurgeons I know don't even respond to my emails on the first time. And if you don't get responses, don't be concerned. They may have just not seen it. It's very common. Stay open-minded. You never know when a door may open. I remember in college, I was mountain biking and I was talking with someone like right when I ride finished, and we were just at the parking lot, and I found out he was a trauma surgeon. And then I shadowed him like a month later. So, you never know who you're going to meet. Just always be kind and open-minded. It's an incredibly small field, functional neurosurgery and neurosurgery in general. So, always be aware, be collegial with all. You never know who's like cousin or neighbor or wife or husband. So, just always be aware. And at some point, you really should become involved in research if you want to do functional neurosurgery. You may not do it for the rest of your life, but you're always going to be interacting with research, and you need to know how to conceptualize it, understand good versus bad research. And there's a lot of different ways to do research, which I'll talk about here. And read. And, when people shadow, I think one of the biggest pet peeves of neurosurgeons is that when you're asking questions, try to ask questions that you can't look up. Maybe, if you're before you ask a question, think out loud, like, is this something I could just Google really quickly? Because if it is, maybe Google it and then ask a question. Like if someone were asked, like, what is the percentage of patients with epilepsy? That's something you probably could just look up. But you could ask, maybe like, what has it been like to become a functional neurosurgeon, or maybe ask, I've noticed that a lot of people with epilepsy have, or there's a lot of people with epilepsy that aren't getting epilepsy surgery. Why is that? So I think that that's always a good just thermometer before you ask questions, because otherwise maybe it seems like you're less involved, but asking questions that are really in depth is always a great sign, and people like thought-provoking questions in general. And then you can always attend grand rounds, online lectures, online conferences. Since 6 years ago, since COVID, so much has become online, and it's really incredible. There's so many resources. You guys probably know a lot more than I do. And then find a mentor. Ultimately, as you go through neurosurgery, things become a lot more apprenticeship style, and it's good to have someone to look up to. So, when I was in med school, I did interviews for people applying to med school. And I would say in general, there's just so many applications. So you got to find something to stand out. When they go through these admission processes, people say, oh, that that guy who was, a near professional figure skater. Everyone always has like a sentence they refer to someone by because there's just so many. So, it doesn't have to be something like that, but you just have to be passionate about something. It could be that, you were so passionate about, a food bank and you expanded it to, multiple counties. It just has to be something. It's just something to stand out. Um, and it's better to be devoted or a leader to two or three interests than like a dozen interests. It just shows that you can follow through on something. And again, talk about what you love. I remember during my talk or during my medical school interview of where I ultimately went, we talked about like biking, like most of one of the interviews. And I remember another one we actually talked about brain implants, funny enough, because like I had read something on, like, it was like a popular science magazine. It wasn't even anything like overly academic. And another one I had talked about, like living near a farm. It just, once you get to the interview process, they just want to know that you're someone that can hold a conversation and is excited about what you do. So yeah, interviewing is about getting to know someone, not their CV. They look at your CV before they get there, and then they use your CV as a way to set discussion points. And then the other thing is you got to you got to have humility because, like I said, if you're in high school, you probably have maybe 16 more years before you could become a functional neurosurgeon. So, and even now, I always, whenever I am like maybe questioning something, I start out with, hey, like, I know you've been doing this a lot longer than me, but like, is this, I may like question something about how we're delivering care for someone if I maybe have read a new article or something, but you always, come in with humility um, and try to be open-minded because, you could be wrong maybe about something. So, um, gen general advice. 60% of the time, it works every time. So I show this here because, you start with structured schooling and as you go on, everything becomes more apprenticeship style. Like, as you become a functional neurosurgeon in fellowship, what I'm being trained on has only been around maybe 5, 10, 20 years. So there's only maybe a couple dozen people doing it, and they're going to teach you their technique. So, take things with a grain of salt, but keep an open mind. And this is residency. Just stay positive. You know, it is true to a degree. It is hard and there's long hours. So, patience and perseverance is important. And but enjoy the process. This is Kipchoge, who's a really famous runner, and he's credited with adjusting this quote to "Life's not about waiting for the storm to pass, but learning to run in the rain." So learn to enjoy the process, even though it can be painful at times, and find camaraderie along the way. And look at what the attendings are doing daily, not the resident. Residency is temporary. It can be long, but when you look at this, emergency medicine's over here and satisfied with work-life balance, but they have a really high burnout rate. If you look over here, and neurosurgery's over here, and they actually have a pretty low burnout rate relative to some of these other ones over here. And they're not satisfied with their work-life balance, but they have a less of a burnout rate. And what that means is that they find a lot of joy in what they do. And it's not everybody. I think it's probably better. This is about 10 years old, this graph. So it's probably better than this. But burnout's not everything and satisfaction's not everything. So you got to take everything together in your decision. So, I'll try to speed things up relatively fast here, but research, I just wanted to show you that it's not a must, but if you're not doing it, you need to set yourself out in some way. And that usually means being a leader in something. And there's a lot of different ways to do medical research. This is just some publications I've done across the years. This was like interviews we did of people about their hand injuries when they were rock climbing, and we got grants to do this. This was lab research where I studied like under using NMR to look at nanofibers and bioscaffolds to really hard organic chemistry, or sorry, non-organic chemistry research. And then I did outcomes research and spine surgery. I did case reports. This one's about using a different type of device for spine tumor sections. This is a video I did about clipping an aneurysms by like through an incision right above the eyeball. Another report about brain bleeds and scuba diving, another video, and this is a cadaveric study studying how fluid shifts in people's brains when you do this specific type of pain procedure. So lots of ways to do research. Just because you hate lab research or you hate statistics doesn't mean you can't do research. So, keep an open mind, and you might find something you're interested in. And when you do approach research, I would say understand your expectations and what they expect. One of the biggest pet peeves is when someone says, "Hey, I'm really excited. I'll give you 40 hours a week. We'll get this done," and then they don't get it done. And I'd much rather hear someone say, realistically, say, "Hey, all I can do is 10 hours a week, and I can do it by, May 1st," because you know what to expect then. And when they do it, you're very excited because a lot of people, kind of fade away. So, biggest thing is, sticking to your word. I think it's really important. Again, stick to timelines. Look for a lab that has past successes. That's always really important. And take ownership of your work. It's better to do one project that you really dive into, become the first author, and do it all, versus maybe being remedially involved in about 10 different projects. So lastly, no one wants to be this person. Um, and you're going to have days like this quite a bit. So, find mentors with success in and out of the hospital. I think it's really important because people can hide things at work and not realize how dysfunctional their life can be. Build relationships in and out of the hospital. Like I said earlier, every time I moved somewhere, I would always go rock climbing gym and meet people, and it was a great outlet for me. I didn't ever talk to center. At the same time, you want to learn about uh, joy.
I'm sorry, Dr. Piper, your connection seems to be a little unstable.
Uh, or how long research you're going to be home yourself. Uh, how long ago did that cut off on you guys?
It's fine.
Oh, just
Just
cut
like
off.
2 minutes. Yeah.
Oh, perfect. Okay, so I think we're down to the last slide anyways. So, um, yeah, so do something for yourself and narrow your scope. Try not to have too many hobbies or too many interests. Ultimately, you're going to want to choose something. You can't be a subspecialty um, specialist in 20 different things. And again, this is advice is always a work in progress. I haven't learned how to do all of this, so I'm still learning how to do all of this. And then lastly, don't get so busy making a living that you forget how to make a life. When you go to residency, most people find their partner there. Most people will have kids if they want to have kids during that time. It's, you can't wait till you're 40 to start your life. So it's my contact info. You're all welcome to email me with any questions or any thoughts if you don't get to answer them during this time. But it's an amazing career, so good luck.
Thank you so much for the amazing presentation, Dr. Krieger. I do have some questions in the chat, and
Yeah.
one of them is, how has your functional neurosurgery training influenced the way you approach skull-based tumors, particularly in terms of preserving network level connectivity rather than just gross anatomical preservation?
Yeah, that's a really high level question, actually. Some people take the approach of, I want to be a functional neurosurgeon. All I'm going to do is functional neurosurgery. And other people take the idea of, I see the future in the blends of different subspecialties. And that's kind of what I took initially. So specifically, I think the question was on how does functional neurosurgery affect resecting tumors? Um, well, I think. The skull-based neurosurgery often involves kind of going around the brain to get to tumors that are deep-seated, and functional neurosurgery often involves getting to deep areas by going through the brain. So, sometimes when we're trying to plan to do a epilepsy foci resection that's deep, skull base has allowed me to think of new approaches. So I did a lot of research and a lot of work by doing transorbital surgery for like deep tumors near like Meckel's cave. So we do an incision in the eyelid or incision in the eyebrow and go this way. It allows us to, because the back of your eye as a skull is not really structural for a large amount. You can take it off without having any real consequences. So when you have a really medial temporal lesion or even a like subfrontal lesion that's causing seizures, you can actually do an incision here. And that's something that I've been working on that not very many people are doing in the epilepsy world. So it's a kind of a completely new way to approach different epilepsy foci by kind of going around the brain. Otherwise, you have to do an incision here. You have to move all the scalp forward and dissect through the temporalis. You do a larger craniotomy, and then sometimes you even have to go through normal brain tissue to get to it, depending on what part of the area of the brain you're trying to get to.
Yeah, that makes sense. Thank you. Another question is, when operating on deep skull-based lesions, do you incorporate prooperative tractography or connectomic mapping to predict postoperative cognitive or affective outcomes?
Yeah, and tractography is incredibly important, and it's not just being used in the functional world. It's being used by tumor surgeons and skull-based surgeons and general surgeons. I mean, and basically, what that is for people who maybe are not as familiar, MRIs show you like the anatomical aspects of the brain, but there's tracts of white matter going from all the gray matter in the brain that you can't see well on MRI, but you can do specific types of imaging to build that and understand where that area, those tracks are going. So you can have an idea of if you have a tumor sitting in this part of the brain and there's an important like motor track right next to it, it's definitely displaced and you can have an idea of where those important fibers are. So Yes, I use it for tumor surgeries all the time. We use it also for planning DBS or creating lesions via ultrasound. We can overlay those tracks and make sure that we're either ablating or modulating the areas that are actually involved in the aberrant tract of the movement disorder.
Great answer. Thank you. So, Dr. Piper, I know that your work involves complex anatomical considerations like Michel's cave positions. So, do you think that medical students and early trainees get enough exposure to functional neurosurgery compared to other specialties?
I mean, it's a hard question. Like, probably not, but I mean, in general, most people aren't exposed to this, there's not that many functional neurosurgeons in the country. I have no idea actually how many there are, but probably less than like fellowship trained, probably less than 200. So, I don't know if it's really warrants medical school spending a whole day talking about functional neurosurgery when, there's less than maybe 200 in the country or so. But yeah, it's definitely something that's probably not exposed to most people. And what is important is Parkinson's disease and epilepsy. Those are huge areas that you're going to learn about in med school. And I think that the biggest problem with functional neurosurgery is that, we aren't always referred patients for deep brain stimulation or epilepsy surgery until sometimes it's too late. Sometimes the patient has had it for so long, their seizure networks have spread throughout the brain, and there's no surgery that we can do to cure them. or they become so cachectic and become so old and such a bad surgical candidate for DBS that they're not a candidate anymore. So, yeah, I would say that, those these different surgery paradigms should be taught so that, at least even if you're not considering functional neurosurgery, you know when to refer.
Okay, I see that Michael raised his hand.
Hello, Dr. Keaton Piper. Thanks for
Hey.
presentating. So while you were studying for this specialty of function surgery, what was the most important class, let's say from undergrad, that helped you?
Hmm. Um, that's a good question. Undergrad was so long ago now. But I think that what I remember was probably one of the most informative things was I was doing a lot of research, and in a basic science lab and talking with a lot of, other physics majors or chemistry majors doing like research solely focused on research. And then I did a study abroad in Sweden studying healthcare systems, and I got more exposed to other pre-med students who were a lot more talking about, clinical aspects of medicine and seeing like the direct effects of, research. And I really liked that. And I did that because I really liked I did that study abroad because I really liked my organic chemistry teacher. So organic chemistry, I became a teacher's assistant or whatnot, where you're like teach some classes. Um, because I really admired my lecturer and he made it fun and exciting. So organic chemistry, just because I liked the mentor, and then he got me into the study abroad, which I really enjoyed, and it's probably ultimately why I decided to do med school, not a PhD. So,
Thank you.
but you don't have to like organic chemistry. You can like psychology and still be a functional neurosurgeon. So.
Yeah, great answer. Um, so Dr. Piper, I know that many of your studies focus on optimizing surgical technique. So from your experience, I wanted to know what aspects of the patient journey outside the operating room still need um most improvement.
Hmm. Aspects of the patient journey? I think it's really institution dependent, which makes it hard. There's kind of issues with every institution. There's great things about every institution. You know, cross residency, I think I was at maybe 10 to 20 different hospitals. So man, I think that what I run into the most is trying to correct preconceived notions of patients. By the time they get to me, usually someone had told them some incorrect information, and I spend maybe 75% of the visit trying to explain to them why that's not the case. Some people say, "Oh, well, like, I finally decided to come here because I'm now 80 and someone told me I can't have DBS surgery till I'm 80." And like that's not the case at all. Like we don't know where that came from, and we just had to like explain that to them. And other times it's, an epilepsy patient who, someone said like, "Oh, you're gonna try to resect part of my brain." Like, I don't want that. And it's like, no one's gonna make you do anything. We're gonna go through the evaluation, and then we're gonna, suggest, we may suggest that we put an electrode in this area. That may be your best outcome. Or we may say, actually, yeah, maybe resection is a good option for you, but if you tell us that, I have an aversion to that, or that's some reason why I don't want to do that, then we would come up with alternatives for that patient. So I think some people may see, brain surgeons as someone that is going to like domineer their will on someone, as it's just not the case at all. So it's just changing a lot of preconceived notions is um, probably the hardest part of the process.
Another question is, in epilepsy surgery near eloquent cortex, how do you balance seizure freedom with preservation of distributed cognitive networks?
Yeah, it's a great question. So, you see the brain as eloquent cortex over here, and then which is like important areas you don't want to touch or it's going to cause some permanent deficit, and then areas where the seizures are coming from. And when you have these separate, it's easy. You know, you resect this area, you leave that alone, and then there's gray area too in between. And sometimes it overlaps, and sometimes you do intraoperative testing to try to find where that line is, or you do preoperative testing, or you just have to take as much as you can, and then you're not going to take eloquent cortex. You may say, hey, we may be able to reduce your seizures by 80%, but we're not going to get you 100% free. And what you can do is you can use electrodes intraoperatively, and you can actually put them around the area that you're planning on resecting and look for changes on those electrodes called intraoperative electrocorticography and see if any of those areas. So you have a very clear area you're going to resect, and then you put the electrodes around that area, and you may see, oh, over here it's very silent, no seizures happening. And then over here, you may have concern for seizures. So then you can either take that area, or if you're concerned of it being eloquent, we often will have the patient awake in the surgery. And whatever we're concerned about it being, we will test that. So we'll actually stimulate that area. And if it's maybe the hand area of the motor strip, then we'll have them move their hand and stimulate it. And if it does correlate, they'll stop moving their hand, and we know we can't take that area. But if it doesn't correlate, then we can take that area.
In patients with skull-based tumors who develop seizures, how do you distinguish mass effect irritation from an independent epileptogenic network?
In patients with skull-based tumors and mass lesions, how do I determine seizure areas versus what?
Um, Distinguish mass effect irritation from an independent epileptogenic network.
Um, well, with skull-based lesions, usually they're something we call extra-axial, meaning not within the brain. They're actually around the brain, pushing on the brain. So in general, if in general you try to take out the tumor, it has a very discrete line, and you can usually kind of take out the tumor and hope that the mass effect's going to go away, unless there was maybe you had a higher suspicion that the seizures were coming from a more broad area, which usually is not the case with skull-based tumors. They often don't cause seizures. Um, then you can do more testing, but in general, you focus on the tumor. If you have intrinsic tumors, which are not usually skull-based, they're usually tumors growing from within the parenchyma. That's a little more complex, and that's when you would probably utilize intraoperative electrocorticography. So.
So you've worked in outcomes research, translational research, and now highly technical neuromodulation studies. So I wanted to know, how do you decide which research questions are worth pursuing?
Yeah, I was really glad that I did research in a lot of different areas because I feel like I have a lot of different tools to use to answer a research question. Um, but I know people who have just, one of my biggest mentors, Eddie Chang, he's stayed with the same research trajectory for his whole career, and he's now the chairman of UCSF. He's been incredibly successful. So there's a lot of different ways you can do it and decide. But for me, when I was trying to decide what research projects I wanted to get involved in, it early on was focused on what subspecialty I was kind of leaning towards. And then mid-residency, I started designing my own ideas. I started when I was in cases that maybe I had done before. I would always try to think how can I improve upon this? Like, is there a research question here? And always just trying to think about that. And then I would usually just kind of create a list. And I was a big person with lists and note cards. And I would always just kind of create a list and just keep those in the back of my mind. And every once in a while, one or two would pop out that seemed like something that I could expand upon, or I'd bring up an idea. I'd maybe propose one of the ideas I had with one of the other attendings or residents and get some feedback and just kind of see which one grabbed footing. So. These are great questions too, and like, I'm open to answering any questions. It doesn't have to be overly complex on functional or skull base, but these are incredible questions. These are questions that a lot of residents would, ask. So it's a great job.
Yeah. And a question by Alyssa is, how did you get started with research? And did you do everything through your universities?
Yeah, I did do everything through universities. And I started initially, kind of as I said, in undergrad, by it's kind of a different path, but than what you see in medicine per se. But um, I think there were like some departmental talks about people looking for undergrads or grad students. And I went to one of them, then I approached one of the grad students and asked him about the lab. And I was like, hey, is there any role for me? And then I went there and I worked with him for like a month and the guy quit. And then the PhD who was running the lab was like, well, you can take over his research if have the bandwidth. And it was kind of just like a sink or swim thing. And, and I just dove into it and I spent a lot of hours. I remember like being there, in the lab, a lot of Friday nights and undergrad. So, that was one way. And then in med school, again, there's lots of different, research talks where people come and like talk about their different research, maybe at grand rounds. But also, what I would say is everyone in academic medicine has some research thing going on. So, even if they aren't publicly advertising their research, a lot of surgeons or medical doctors have like case reports and case series that you can get involved in. And those are relatively easy to get started. And even undergraduate students could probably do that whole project as first author if they're motivated. So I think that that's a really great way to start. But if you wanted to have bigger research that would involve grants and whatnot, then you would probably need to approach someone that has a history of publishing like that. So if you're interested in a medical research group, you should look them up, like maybe the senior author up on PubMed, and see what they've published and see their track history.
Makes sense. Thank you. And Dr. Piper, I know that you focus heavily on refractory plane, which is sometimes considered less flashy than tumor or vascular cases. So, what drew you personally to treating pain patients?
Yeah, the functional neurosurgeon I worked with in residency, I liked because he did a little bit of every pain and he seen every surgery. Like he did a lot of different types of surgery from spine to tumor to DBS to epilepsy to peripheral nerve stimulation. He kind of seemed like the guy that everyone went to when they didn't know what else to do with the patient. So I really liked the idea that, functional neurosurgery is the area where when no one knows what to do, they go to that person. And it can be hard patients. These are patients who have tried everything. Maybe they've had 20 to 40 back surgeries, or they've had excruciating pain, have been admitted for, multiple suicide attempts because their pain's so bad. And so, I mean, it's like really hard to deal with, for the patient, and, the clinics can be hard. These are patients who are in excruciating pain, but um, you're kind of like the end of the line. You're kind of like the last resort. And I like that idea of being, helping this underserved population that, sometimes is neglected. Sometimes people don't want to see these patients in their clinic. It can be a lot of time you have to spend with them. And really, you have to decide, what the right surgery is for them, because in pain neurosurgery, sometimes people get the wrong surgery and then they're miserable. And I think they're really complex. So I like the idea of being kind of the last resort and trying to work through a really complex problem.
In patients with medically refractory focal epilepsy, how do you distinguish the true epileptogenic zone from secondary propagation networks when planning surgical or neuromodulatory intervention?
So It's kind of like the first case that I showed in the sense that sometimes you get a scalp EEG and it's pretty clear where it's coming from, and an MRI maybe shows focal cortical dysplasia or something like very clear, and you don't need to do anything else, and you have a very like high likelihood of where it's coming from and high pretest hypothesis, and you propose a plan to the patient and it works great. And other times you don't know. That's exactly like what the question's saying is you don't know if it's propagation or if it's where it's arising from. And those patients, you need to do stereo EEG, which is when you implant the depth electrodes and record the brain. But you have to have a really good idea of where it's coming from. If it's like the whole brain, you can't put electrodes everywhere. You need to know, you have to have a question you're answering. Sometimes I don't know if it's right versus left temporal lobe. So you put some here and some here, or other times it's, I don't know, temporal lobe versus frontal lobe. They have features of each. So you do that. And even after that, sometimes you don't get an answer. And it could be because maybe the electrodes didn't have a high enough density coverage of everything, or it is that the patient is having a wide early onset of their seizures. And in those cases, you can't, there's nothing that can really cure them. There's other palliative procedures you can do to reduce their seizures, but they won't ever become seizure free with the current technology we have.
And I see that Michael raised his hand again.
Yeah.
Hello, doctor. You mentioned how medicine is also evolving, not only in the practice but also in school. Like now, in where I'm living currently, in community colleges are allowed to have cadavers, and if you're wondering, cadavers are actual human bodies or that have been donated. So I'm really taking advantage of the opportunity, and that's unusual having community colleges having that opportunity. So I'm currently in the cadaver section. So what advice, specific and non-specific, could you give, maybe for not for us, but for any students who are going to the cadaver section?
Yeah, I loved my anatomy class first year of med school, and I actually took one at the end of undergrad as well. And having like access to a cadaver 24/7 it's a great experience. I mean, you have so much you can learn, and I mean, it's just such an amazing gift that you're receiving. So I would say that from the neuro side, I think you're probably learning about cranial nerves, and that is a really important area. I still, use those all the time. And um, I don't know if you have access to like the interparenchymal aspect of the brain. I remember in my cadaver course, we didn't actually dissect the brain, but we got to look at slices of it. And so, I mean, if you had a opportunity to actually like look at the basal ganglia and look at the different stainings of it, I think that that's a unique opportunity. I think when you're looking at it, just think of it clinically, because sometimes they just teach it to you anatomically, so think of these different areas, and I'm sure there's clinical correlates where they say like sometimes tumors come from this area. So if they tell you a tumor is coming from this area, think about if I was a surgeon, like how would I get to that area? Because like also you have this really unique situation where, I've been training to do this for 20 years, and everyone's already taught me. Like I know like if there's a tumor in the temporal lobe, I'm just gonna think, pterional or FTOZ or transorbital, like, I'm gonna think just the classic routes, but you haven't learned any of those. Like you may be someone that creates a completely new approach that no one's ever thought of because, you haven't been muddled with all the history yet. So I think that if they have clinical correlates to anatomy, then just try to think outside the box, and I think that's also what's exciting about medicine. Like improving upon the people who have been here before us. So
Another question I had for you was, where do you see functional neurosurgery evolving in the next 10 to 15 years? And what skills should students be developing now if they're interested in contributing to the field?
What skills should they, what?
What skills should they be like developing right now if they're
I
interested?
see. Yeah, I mean, of course, AI is going to be integrated into all these brain computer interfaces and these devices that are being implanted. And, that's going to be a big ethical and incredible advancement. But I think that what's really happening right now is optimizing something called closed loop stimulation. So previously, when we're doing stimulation, it was just stimulating deep in the brain. But now well, not me, but other people have designed incredible electrodes that sense, they actually record the brain from different contacts and then they stimulate on nearby contacts. So they have all these like, 8 or 16 contacts right next to each other, and they can pick which ones are actually going to be sensing and which ones are going to be stimulating. And that's a relatively new advancement. It sounds relatively simple, but this idea of like a closed loop stimulation circuit is really going to, I think, take off. I think that additionally, we're choosing closed loop stimulation based on there's something we call local field potentials, which is like recordings of the brain, and we don't fully understand those. So, understanding what we're actually recording to determine how we're going to adjust the stimulation is going to really be important. And I think that it'll ultimately answer hopefully it'll answer how does like DBS work? It's been around for 30 years, over 30 years, and we still don't fully understand how it works. We know it helps patients and we know it, mimics either a lesion or adjustment in that network, but we don't know how it works fully. So, oh, and skills. Yeah, so skills, I mean, I don't think you have to be a computer programmer to be a functional neurosurgeon. You're dealing with computers a lot, but you don't have to be a computer programmer. You just, the most important thing is you're a clinician first. You're going to be seeing patients. Like, if you go whole away for the next 12 years in the library and then try to become a functional neurosurgeon, you'll never get a patient because everyone's going to think you're too strange and won't be able to relate to you. So, just in general, you have to be a human first. And then I guess more niche to that is it is important though to kind of understand if you're looking for like things to study as a functional neurosurgeon is like understand networks and understand the less studied areas of the brain. In residency, you learn a lot about how the body moves and how you talk, but you don't really learn a lot about cognition and how we preserve memories, how memories are created, how we think, like where consciousness is. All that is like relatively understudied. And that will probably be an expanding area in functional neurosurgery.
When selecting between subthalamic nucleus and globus pallidus interna for
Palatus, yeah.
pallidus interna for
Yeah.
DBS and Parkinson's disease, what patient-specific factors most influence your decision?
Yeah, I mean, it's relatively streamlined now. Those are the most two common targets and most well studied. The subthalamic nucleus, um, people would probably argue is slightly more targeted and more of maybe a gold standard in the sense that patients with Parkinson's disease get a lot of problems with their medication they need, and subthalamic nucleus is really good at reducing the amount of medication they have to take. Um, so that's one of the big things is if you're trying to reduce the amount of medication they're taking because they're getting side effects or some other reason, then subthalamic nucleus is really helpful. If they have some other cognitive issues or underlying psychiatric issues, and that's sometimes by stimulating the subthalamic nucleus, you can get exacerbations of that. So you will often choose GPI or globus pallidus internus for that reason. Sometimes, if they have some dystonia or specific types of dyskinesias, GPI is a better target as well.
What would you say is your bread and butter procedure as a functional neurosurgeon?
Probably the most common is DBS, deep brain stimulation. And that's a great question because you got to think about whatever you're choosing, you have to like the bread and butter. So, if you are wanting to do be a spine surgeon because you love to take out spine tumors, you're gonna have to like to do just a general laminectomy. And if you want to be a, general surgeon, you have to like appendectomies. So, yeah, functional neurosurgeon is deep brain stimulation is probably the most common. And then maybe secondary to it is um, either some type of epilepsy surgery, either like an epilepsy resection or implantation of depth electrodes.
Maria says, congratulations on getting another little one on the way.
Yeah.
And was there a moment in training where you questioned your path or were completely sure?
Oh no, you're gonna question it the whole way. I mean, everyone does, whether they're honest with it or not. But hopefully, along the way that you have more moments where you're excited about it and you're just thinking, man, this is incredible because, there's so many times where you're, just standing in front of someone's brain, whether awake in the OR, and you're just thinking like, what an incredible privilege. Like, how many people get to be a part of this and then, after surgery, like even more gratifying is when someone tells you like what an impact you've had on their life. We're really lucky as neurosurgeons that, people give us a lot of praise afterwards. I mean, everyone's going to have some bad outcomes. There's complications that are unavoidable and it's hard to deal with. But for the most part, if you've trained well, you're going to have a lot of great outcomes. And I mean, it's really incredible. There's some patients that just come to clinic 20 years after their surgeries just to because they want to thank their doctor again. So, it is really gratifying in that sense. And because you're a surgeon and things kind of boil down to, one day and one procedure, a lot of times you're really remembered. And unfortunately, sometimes a lot of people that are doing the other leg work, like maybe that epileptologist or other people, maybe don't get as much credit. It's something we're really honored to, be thanked for our work. And there's a lot of other people that do a lot of work as a team that don't get thanked for it. So.
Michael, you can go ahead.
Hello. I mentioned about anatomy earlier. Well, yes, it's rewarding that we get to see the models. If they're currently we're learning models, such as we're able to see the cutaneous membrane, which is the skin of the model.
Mhm.
But one of the biggest shocks that I'm learning about is that we're looking at the cellular level, the histology of it. And I'm wondering for at least neuros, I don't know if they emphasize it in histology for functional neurosurgery. Is there even are the neuron cells, I believe, even more differentiated than that of the epithelial cells?
Ooh, hard for me to say because I don't really remember all of the epithelial differentiation well. But in general, there's a lot of neuronal cells and areas in the brain that have names and we don't even understand what they do. There's an area of the brain called the claustrum that no one actually knows what it does. There's a lot of areas in the brain that we don't really know. So as far as unknown, yes. As far as like variety, I'm not sure comparing to the skin, but you know, some of it's nomenclature. There's probably more nomenclature in neuro, but as far as understanding it. Um, there's probably more details in the skin, and they would probably understand how the epithelial cells work a lot better than we do with the neurons. Um, you have glial cells, and then down in the cerebellum, you have a lot of different types of cells which are more differentiated and maybe less known. But sorry, I don't have a great answer for you. But regardless, you're going to learn so much in med school and you're going to forget a lot of it. And then you're going to relearn a lot of it that's important clinically, and you're going to think that you didn't remember it from med school, and then you're going to see a patient and someone's going to bring up basket cells, and you're going to be like, oh wow, I remember that from my neuro section. So, maybe you feel like you're not retaining it, but I bet you're retaining more than you think.
Thank you.
A question by Jennifer is, do you currently work or have you previously worked with veterans who have treatment-resistant PTSD or traumatic brain injury? And if so, what role does functional neurosurgery play in their treatment?
Yeah, that's a good question. I bet it's going to be an evolving field. It's not overly involved in it right now. PTSD is huge, and yeah, I spent a lot of time at the VA, the Veterans Associate or Administration Hospital in residency, and a lot of patients unfortunately have PTSD, and even patients in general hospitals do as well. But as far as in the functional neurosurgery capacity, there's not really any surgical intervention that has been shown to be helpful for that. There are some DBS being studied for depression now, which is really exciting, and pretty promising actually, as well as some other stimulation like vagus nerve stimulation. And then I know that there's some more work. I'm not as privy to it. I'm not doing any research in this, but I know there's some work being done with transmagnetic stimulation for PTSD. So uh, those are kind of like functional adjacent, but they're not surgical.
Okay, and this is probably going to be our final question for today. So, with AI becoming more common in medicine, like charting, imaging, and decisions tools, have you noticed it change your day-to-day work at all? Like, has it affected how you interact with patients?
Yes, actually, really only for the betterment so far. It's been kind of rolled out very cautiously. But I would say that the one way that I've found it very helpful so far is we have something called AI scribes, where you can, inside the electronic medical records, you can actually like just turn on a recording system and it will listen to you and it'll generate a note in your writing style. And then afterwards, you have to read through it and make sure it generated it correctly. But you don't physically have to type out your whole note anymore. You just have to make adjustments to it. So it's pretty great in that sense. It can save a lot of time and allow me to spend more time with the patient and not be typing at the same time that I'm talking to someone. So it's been really helpful with that. But I could see it really be misused if someone doesn't check what it wrote out. You have to double check everything. And I use it actually a lot with research in the sense that maybe I'm trying to find a pivot point to look for something. Maybe, I'm looking for a supporting article for something I knew, and then it would maybe give me a link to an article, and then I go read the article and, confirm like, oh, this is what I wanted, and then look at the references of that article and find, oh, this is another article actually I was looking for. So in research, I think it's really helpful to be like a research assistant. But you got to be really cautious because like if you just, ask AI to generate a research report to you, it can hallucinate and just, come up with articles or misquote articles. So yeah, just be very cognizant, but it can be very helpful.
Okay, that's it for the questions, Dr. Piper. Thank you so much for taking the time to join us today and share your expertise and perspective as well. And we are so grateful about how thoughtfully you explained everything.
Of course, yeah. Good luck to everyone. Hopefully your path becomes a functional neurosurgeon, but regardless, whatever you guys decide to do, just do it because it's something you want to do and are excited about. So,
Okay, so right now I'll just do a short rapid presentation. Dr. Pepper, you're free to leave if you'd like, or you can stay to just answer any final questions people have.
all right.
Just make this real quick. Okay, thank you so much for joining today's session, everybody. These are the three questions I have for you right now, which is what was your favorite moment, and what's one idea from today that you're most excited to explore next, and what's one key takeaway or idea that stood out to you the most? Feel free to answer these questions in the chat or as a PHS reflection on the website. Other than this, you can also share your insights on LinkedIn by tagging pre-health shadowing. Other than this, once again, if you're interested in being part of the pre-health shadowing team, you can do so through the link on our website or in the chat, and it's 100% remote. And you could also sign up for our leadership team. And it would be really great if you guys could donate. That could be by donating either money or your valuable time with us. Don't forget to take the digital quiz on the PHS website after this session, which allows you to get a digital certificate for attending. You can do this by answering a 10-question simple multiple choice quiz based on the presentation. If you missed part of the session today, you don't have to worry. You can just visit our YouTube channel at Pre-Health Shadowing, and you can watch any of our previous sessions for free. Be sure to catch on our sessions every week by following our newsletter or the PHS website. And thank you so much for joining, and stay back if you have any questions. Thanks, everybody. Okay, I'll just end the session. Thanks for joining, guys.